In the rapid revision series, the next topic that I'm taking up is renal. So let's look at the first concept as far as renal physiology is concerned, and this is the glomerular filtration membrane. We know that the glomerular filtration membrane has got three layers. The glomerular capillary endothelium, which is a fenestrated endothelium. It has large pores. The basement membrane and the Bowman's capsule. The visceral layer of the Bowman's capsule is modified to form podocytes, and podocytes have these foot-like processes, and between the foot-like processes there are filtration slits. What is the limiting factor for filtration? Basement membrane. Now, the filtration in the glomerulus requires these pressures. And what are these pressures that we are talking about? Number one is the glomerular capillary hydrostatic pressure, which is a push force. It pushes the fluid out of the glomerular capillaries into the Bowman space. A pull force of the glomerular capillaries is pi Gc, colloid osmotic pressure of the glomerular capillaries. Similarly, the Bowman's capsule also has a push force, that is the hydrostatic pressure of the Bowman's capsule, and a pull force, which is the colloid osmotic pressure of the Bowman's capsule. So what are the forces which are favoring filtration? Favoring filtration are PGC and pi BC. From the direction of the arrows, you should be able to appreciate. PGC is directed from the glomerular capillary into the Bowman's capsule, and so also the pi BC. What are the forces which are opposing filtration? Opposing filtration are pi GC and PBC. Again, you should be able to appreciate this from the direction of the arrows. So what is going to be the net filtration pressure? The net filtration pressure is PGC, which is the largest force, minus pi GC minus PBC. Why are pi GC and PBC taken as minus? Because they are opposing filtration. Plus pi BC, and pi BC is a plus because it is favoring filtration. Forces which are favoring filtration will have a plus sign, and the ones which are opposing filtration will have a negative sign. How much is the normal value? PGC, the hydrostatic pressure in the glomerular capillaries, is the highest out of all the capillaries in the body. Normally, the PC, hydrostatic pressure in the capillaries, is about 35 millimeters of mercury, but in the glomerular capillaries, this is 45. Minus 20, minus 10, plus 0. Why is pi BC 0? Because there are no proteins in the filtrate. Colloid osmotic pressure is because of proteins, and normally no proteins are present in the filtrate, therefore pi BC will be 0. This gives me a net filtration pressure of 15 millimeters of mercury. Some books say that the net filtration pressure is 10, but 15 is a slightly better answer. Now, the GFR, or the glomerular filtration rate, will be directly proportional to the net filtration pressure. More the net filtration pressure, more will be the GFR. If I want to remove the proportionality sign, bring an equal to sign, I have to multiply it by a constant. The constant is Kf, or the ultrafiltration constant, into PGC minus pi GC minus PBC plus pi BC. And what is Kf? Kf is a product of permeability into the surface area. So that means, which are the factors which affect filtration? Number one, permeability. Number two, surface area. More the surface area, more the filtration. Number three, PGC, pi GC, PBC, and pi BC. So please remember, for example, if there is an increase in the renal plasma flow, this will increase the hydrostatic pressure of the glomerular capillaries, favoring filtration, increasing GFR. Let's take one more example. Supposing there is an efferent arteriolar constriction. The efferent arteriole is constricted. So that means outlet from the glomerular capillaries is narrow. So it creates a back back pressure. When it creates a back pressure, it will increase the hydrostatic pressure of the glomerular capillaries. And PGC favors filtration, so what will happen to GFR? Increases. Let's take one more example. Supposing there is a ureteric stone. That means flow of urine is getting obstructed. Again, this creates a back pressure, and this will increase the PBC, hydrostatic pressure of the Bowman's capsule. And hydrostatic pressure of the Bowman's capsule is a force which is opposing filtration. So what will happen to GFR? Decreases. So these are the factors affecting GFR. Now, there is something known as autoregulation of GFR. Between a mean arterial pressure of 90 and 200 millimeters of mercury, GFR is constant. And this is because of autoregulation. What is autoregulation? Regulation by self. And there are three mechanisms of autoregulation: the myogenic mechanism, the tubulo-glomerular feedback, and the glomerulo-tubular balance. What is myogenic mechanism of autoregulation? Now, supposing there is an increase in renal blood flow due to any cause, this will start causing a stretch of the vessel wall. And because of a stretch of the vessel wall, this causes opening of what are known as the mechanosensitive calcium channels. And when these mechanosensitive calcium channels open, there is going to be an influx of calcium, and influx of calcium now causes the vascular smooth muscle contraction. And if the smooth muscle of the blood vessels contract, what will happen to the renal blood flow? Reduces. So ultimately, the effect is that the GFR is constant. This is what is meant by the myogenic mechanism of autoregulation. Let's look at TGF, tubulo-glomerular feedback. Now, supposing, let's say, the myogenic mechanism was not able to control filtration, and now there is an increase in the GFR. The moment there is an increase in the GFR, now there will be more filtration, more sodium and chloride load in the tubular fluid. This now reaches the macula densa. Where is the macula densa? Macula densa are modified tubular epithelial cells. These are at the beginning of DCT. And these macula densa cells act like a sensor. What do they detect? They detect both the sodium and the chloride load in the tubular fluid. So sensed by the macula densa. Now macula densa, there is more sodium and chloride reabsorption by the macula densa cells. And sodium reabsorption means sodium potassium ATPase activity. If there is more sodium reabsorption, there is increase in the sodium potassium ATPase activity, which now causes hydrolysis of ATP. There is generation of adenosine. Adenosine will act on A1 receptors on the macula densa cells, causing release of calcium. This in turn causes constriction of the afferent arteriole, reducing the GFR. Net effect is that the GFR is going to be constant. This is tubulo-glomerular feedback. The stimulus is in the tubule at the beginning of DCT, sensed by the macula densa, and the effect is on the afferent arteriole. So 2 or 3 important questions. Where are the macula densa cells? These are modified tubular epithelial cells at the beginning of DCT. Function of macula densa: act like a sensor. What do they detect? Only sodium, only chloride, or both sodium and chloride? Both sodium and chloride. TGF is mediated by adenosine, which is a byproduct of ATP hydrolysis. Site of action of TGF is the afferent arteriole. So this is your tubulo-glomerular feedback. The third one is called the glomerular-tubular balance. Now, glomerular-tubular balance is known as the third factor. Why is it known as the third factor? Because this acts when the first 2 mechanisms fail. Which are the first 2 mechanisms? myogenic mechanism of autoregulation, and TGF, tubulo-glomerular feedback. And GTB is pretty simple. It says more the filtration, more the reabsorption. And what is the site of action of GTB? This is going to be the PCT, because maximum absorption takes place in the PCT. Let's have a look at renal clearance. What is renal clearance of a substance? Clearance of a substance is defined as volume of plasma cleared of that substance or free of that substance in unit time. Volume of plasma cleared of that substance or free of that substance in unit time. And what is the unit for clearance? This is ml per minute. Volume of plasma free of that substance in unit time. And what is the formula for clearance? It is UV by P. What is U, what is V, and what is P? Let's try and understand this. U refers to the urinary concentration of that substance. Please remember, when I use the term concentration, it has to be per unit volume. V is the rate of urine flow. Rate of urine flow, whenever I use the term rate, it means it has to be per unit time. And P is the plasma concentration, again in per unit volume. So if you see this, urinary concentration is in milligram per ml. Rate of urine flow is in ml per minute, and plasma concentration is again milligram per ml. These will cancel each other out. And finally, the unit for clearance is ml per minute. Volume of plasma cleared of that substance in unit time. Now, please remember, clearance of inulin is equal to the GFR. Why so? This is because inulin is a substance which is freely filtered, not reabsorbed, not secreted. That means the only process by which inulin is removed from the plasma is by the process of filtration. So the rate at which the inulin is being cleared from the plasma, or the clearance of inulin, will be equal to the glomerular filtration rate. Clearance of para-aminohippuric acid in low concentration is equal to renal plasma flow. Again, why so? This is because para-aminohippuric acid is freely filtered and completely secreted in low concentration. So whatever para-aminohippuric acid enters the kidney will be present in the urine. So the rate at which para-aminohippuric acid is being eliminated or cleared from the plasma is the rate at which the plasma flows into the kidney, or clearance of para-aminohippuric acid in low concentration is equal to renal plasma flow. Now, have a look at this graph. It has been asked in your NEETPG exam. You have plasma concentration in milligrams per deciliter on the x-axis and clearance in ml per minute on the y-axis. Now, we know that the clearance of inulin is equal to the GFR. GFR is 125 ml per minute. So at 125 ml per minute, this is going to be the clearance of inulin, equal to GFR. Now, all substances which are reabsorbed would mean that they re-enter into the plasma. They will have a clearance which is less than the clearance of inulin. So all reabsorbed substances will have a clearance less than the clearance of inulin, and similarly all secreted substances will have a clearance which is more than the clearance of inulin. Because what is secretion after all? Secretion would mean that the substance is being secreted from the plasma into the tubular fluid. So volume of plasma which is cleared of that substance in unit time will now be more than the clearance of inulin. Now let's look at substance D. Now this has, the clearance is 0 below a certain plasma concentration. Then after that particular plasma concentration is reached, the clearance increases but is less than the clearance of inulin. Now, this is the clearance of glucose. Let me try and explain that. So below renal threshold, the clearance of glucose is 0. Now, what is renal threshold? Renal threshold is the plasma concentration beyond which glucose begins to appear in the urine. So if plasma concentration is below renal threshold, whatever glucose is filtered is going to be reabsorbed. So that means urinary glucose is 0. And what is the clearance? UV by P. So if urinary glucose is 0, clearance will be 0. So below renal threshold, the clearance of glucose is 0, but as soon as the plasma concentration exceeds the renal threshold, the clearance will increase, but is always less than the clearance of glucose. Let's look at substance A. Very high clearance in low concentration. This is the clearance of para-aminohippuric acid. Remember, I just told you clearance of para-aminohippuric acid in low concentration is equal to the renal plasma flow. Why so? Because in low concentration, para-aminohippuric acid is freely filtered and completely secreted. But in high concentration, para-aminohippuric acid is incompletely secreted. So the clearance of para-aminohippuric acid decreases in high concentration but continues to remain above or more than the clearance of inulin, because at least some secretion of para-aminohippuric acid is taking place. Substance B is the clearance of creatinine. Why so? Creatinine is freely filtered and slightly secreted. And because it is slightly secreted, so its clearance will be slightly more than the clearance of inulin. Sometimes in clinical practice, we take the clearance of creatinine for GFR estimation. Of course, we know that the clearance of creatinine is slightly more than the clearance of inulin. It's not accurate, but it is slightly easier to do. The reason is because creatinine is an endogenous product. It comes from muscle metabolism. Inulin is a substance which is not produced in the body. I have to give it by an IV infusion, but creatinine is an endogenous substance. So it's easier to do clearance of creatinine, but the point remains it is not accurate. But if you're asked for GFR, would you like to do a creatinine clearance or an inulin clearance? Please say inulin clearance. Inulin clearance is the gold standard as far as GFR estimation is concerned. Next, let's have a look at how the kidney handles glucose. Now, glucose is a freely filtered substance, but glucose will be reabsorbed completely in the PCT itself. And how does glucose get reabsorbed in the PCT? There is a sodium glucose cotransport, which is also known as SGLT. In the kidney, it is SGLT2. Remember, 2 kidneys, SGLT2. And on the basal side, glucose will leave the cell by facilitated diffusion, and the transport protein is known as GLUT2. More than 90% of the glucose absorption occurs in the early PCT, and the proteins involved are SGLT2 and GLUT2. And about 10% of glucose absorption occurs in the late PCT, and the proteins involved are SGLT1 and GLUT1. So 100% of the glucose is going to be reabsorbed, and there is no glucose present in the urine. And reabsorption occurs in the PCT. So site of reabsorption PCT, amount of glucose reabsorbed is 100%, and mechanism is SGLT2 and GLUT2 mainly. Now, there are 2 important terms for glucose absorption. Number 1 is what is known as the renal threshold. Now, what is renal threshold? Renal threshold is the plasma concentration beyond which glucose begins to appear in the urine. Plasma concentration beyond which glucose begins to appear in the urine. And how much is the renal threshold. In terms of milligrams per deciliter, this is 180 to 200 milligrams per deciliter. That means if the plasma glucose is more than 180, then it is possible that glucose will begin to appear in the urine, or you can also write it as 2 milligrams per ml. This is renal threshold. There is another term which is called TMG, transport maxima for glucose. Glucose absorption is carrier mediated, and we already know that all carrier mediated transports will have a maximum rate of transport, which is called Tm. Now, this is TMG, that is the maximum rate of glucose transport or of glucose reabsorption. Now, the TMG in the case of males, this is 375 milligrams per minute. In the case of females, this is 300 milligrams per minute. Please see this very carefully. Renal threshold is a concentration, so this is per unit volume. TMG is a rate, so it is per unit time. So these are two important terms as far as glucose absorption is concerned. Next, let's have a look at how does the kidney handle water. Now, the GFR, as we know, is about 180 liters per day. And just to put it in perspective, now one bucket is 30 liters of water. So 180 liters is actually 6 buckets of water. And the urine production is hardly 1 to 1.5 liters per day. That means most of the water, almost 178.5 to 179 liters of water will be reabsorbed. 2/3 of the reabsorption will occur in the PCT, and that is known as an obligatory reabsorption. This reabsorption has to happen irrespective of ADH. 2/3 of the water, that means 120 liters, is absorbed in the PCT of the nephrons of the two kidneys. The aquaporin which is responsible is aquaporin 1. Then there is more water absorption in the descending thin segment. This is about 15 to 20%, and this also is with the help of aquaporin 1. But please understand, obligatory reabsorption is in the PCT. When we speak of obligatory reabsorption, we refer to the water reabsorption in the PCT. Thereafter, there is no water reabsorption till the fluid reaches the collecting duct. In collecting duct, we have something known as facultative reabsorption. That means this is controlled by the ADH. ADH controls about 13 to 15% of water absorption. Almost 23 to 27 liters of water reabsorption is controlled by ADH. The receptor for ADH on the collecting duct is V2 receptor. Second messenger is cyclic AMP, and ADH will increase the number of aquaporin 2 on the luminal membrane. So facultative reabsorption, collecting duct, obligatory reabsorption, PCT. Let's have a look at the H plus secretion in the kidney. Now, this is extremely important to understand that the H plus is secreted by the kidney. Kidney has a very important role to play in acid-base balance. How does kidney help in maintaining acid-base balance? It is involved in secretion of H plus and in reabsorption of bicarbonate. That is how the kidney helps to maintain acid-base balance. Now, most of the H plus is secreted in the PCT, that is almost 4,200 millimoles per day. In the collecting duct, less than 80 millimoles per day. PCT cells are very rich in carbonic anhydrase, which catalyzes the reaction between carbon dioxide and water to form H2CO3. H2CO3 splits into H plus and HCO3 minus. H plus is secreted by a secondary active counter transport in the PCT. In the collecting duct, the I cells of the collecting duct. Remember, acid has an I. So I cells are involved in H plus secretion. P cells of the collecting duct are involved in sodium reabsorption, potassium secretion, water reabsorption, but I cells are involved in H plus secretion. The H plus secretion in the collecting duct is by a primary active transport, which is H plus ATPase, or it could be an H plus K plus ATPase. But please remember, majority of the H plus is secreted in the PCT. Now, PCT has got a very good urinary buffer, which is called bicarbonate. So whatever H plus is secreted in the PCT, it is buffered by the bicarbonate. So there is no acidification of the urine in the PCT. Whatever H plus is being secreted is being buffered by the bicarbonate in the tubular fluid. On the other hand, acidification will occur in the collecting duct. There are two important buffers in the collecting duct, phosphate and ammonia. Phosphate, H2, HPO4 2 minus, binds the H plus to form H2PO4 1 minus, which is your phosphoric acid. This is what is responsible for acidification of the urine. In the collecting duct, you also have ammonia. Ammonia will bind with the H plus and form ammonium ion. So the buffers in the PCT bicarbonate, in the collecting duct phosphates and ammonia. Another important point, and that is for every H plus secreted in the PCT, one bicarbonate is reabsorbed, and in the collecting duct, for every H plus secreted, one new bicarbonate is generated. So site of generation of new bicarbonate is going to be the collecting duct. I've already told you that kidney has such an important role to play in acid-base balance by secreting H plus and by reabsorbing bicarbonate, and in fact even by generating new bicarbonate, which occurs in the collecting duct. Now, the other important topic in the kidney is the countercurrent mechanism. So before we take on the countercurrent in the kidney, what is countercurrent? Countercurrent is whenever you have two vessels close to each other, parallel to each other, and with flow in opposite directions. We call that countercurrent. Now, countercurrent mechanisms are present in the kidney, of course, which we will just discuss. There are other sites of countercurrent, for example, the testicular vessels. They are also, the testicular artery, the testicular vein are countercurrent with each other, and the countercurrent mechanism in the testicular vessels helps to maintain the testicular temperature lower than the body temperature. And you know that is very important for spermatogenesis. Countercurrent is also seen in the intestinal villi, alveoli, and venae comitantes. What are venae comitantes? Veins associated with certain arteries sometimes also have this countercurrent mechanism, which helps to maintain body temperature. So these are the countercurrent. Now, the countercurrent in the kidney, you have a countercurrent multiplier and a countercurrent exchanger. Now, which is the countercurrent multiplier? Countercurrent multiplier is the loop of Henle. And what is the role of the loop of Henle? It creates the medullary interstitial hyperosmolality. Whereas, what is the countercurrent exchanger? The countercurrent exchanger is the vasa recta, which maintains the medullary interstitial hyperosmolality. Now, what is the role of the countercurrent multiplier or the loop of Henle? And the components of the countercurrent multiplier system is the descending thin segment and the thick ascending limb. Now, the descending thin segment, it reabsorbs only water, and the thick ascending limb reabsorbs only solutes, Na plus, K plus, 2Cl minus co-transport. But please remember, the reabsorption of solutes in the thick ascending limb is more than the reabsorption of water in the descending segment. So what has happened because of this? Now, fluid which enters the loop of Henle from the PCT is isotonic, but because water is getting reabsorbed in the descending thin segment, at the tip of loop of Henle, this tubular fluid is hypertonic, but by the time it leaves the loop of Henle and enters into the DCT, this is going to be hypotonic. Why does this happen? This is because the thick ascending limb absorbs more solutes as compared to the water absorption in the descending thin segment. So if the inside fluid is becoming dilute or hypotonic, what will happen to the interstitial fluid which surrounds the loop of Henle? That will become concentrated. So this helps to create a medullary interstitial hyperosmolality. Now, firstly, why do we say medullary interstitial hyperosmolality? Because this is being done by the juxtamedullary nephrons. You know that there are two types of nephrons. There are cortical nephrons and there are the juxtamedullary nephrons. Majority of the nephrons are cortical, almost 80% are cortical. Juxtamedullary nephrons have these long loops of Henle, and these long loops of Henle go into the medulla. And it is these juxtamedullary nephrons which have got thin and thick segments. Cortical nephrons do not have thin and thick segments. So that means it is the juxtamedullary nephrons which are creating this medullary interstitial hyperosmolality. So countercurrent mechanism is seen in the juxtamedullary nephrons, and these are responsible for creating a medullary interstitial hyperosmolality. Now the next point which arises is that why do I need a concentrated medullary interstitium? Firstly, what is a hyperosmolar medullary interstitium? See, when I look at the cross section of the kidney, the interstitium of the cortex has an osmolality of 300 milliosmoles per liter, isotonic. And as you keep going deep into the medulla, this osmolality keeps on increasing. Deep in the medulla, this is 1200. And this concentrated medullary interstitium is created by the countercurrent mechanism in the loop of Henle. So which are the solutes which are responsible? Sodium, potassium, chloride from the thick ascending limb, and also to some extent urea. Urea will enter into the medullary interstitium from the medullary collecting duct. Remember, ADH also facilitates urea transport. It also increases urea transport. So urea from the medullary. So these four solutes are responsible for a hypertonic medullary, hyperosmolar medullary interstitium. Why do I need a hyperosmolar medullary interstitium? Because it helps me to produce a concentrated urine. For concentration of urine, I need two things: presence of ADH, and number two, a concentrated medullary interstitium. Because water always moves from dilute to concentrated. Right? So now my next important point is, what is the maximum urinary osmolality which can be achieved? The maximum urinary osmolality which can be achieved is 1200 milliosmoles per liter. Urine can never be more concentrated than this. How much is normal urinary osmolality? Normally the urine which is produced is isotonic to hypertonic, 300 to 1200 milliosmoles per liter. How much is the possible? What is the possible range of urinary osmolality? The possible range is 50 to 1200 milliosmoles per liter. 50 when there is zero ADH, no ADH at all, and 1200 when there is maximum ADH. So this is your countercurrent multiplier, which is creating a concentrated medullary interstitium. What is the role of the vasa recta? Vasa recta will help to maintain this concentrated medullary interstitium. Let's have a look at some NEETPG PYQs from the renal system. It says all of the following statements about the countercurrent multiplier are true except descending limb is highly permeable to water. This is true. Thick ascending limb is permeable to sodium and chloride. This is also true. Descending thin limb is impermeable to water. This is false. Descending limb is moderately permeable to urea. This is true. So answer to this is D. Please remember which segments of the nephron are permeable to urea. The PCT, definitely 40 to 50% of urea is reabsorbed in the PCT. The urea re-enters into the plasma. Then the medullary collecting duct, and ADH increases the urea permeability in the medullary collecting duct, and also in the descending thin segment is moderately permeable to urea. All other segments of the nephron are impermeable to urea. Urea, I told you, has an important role also to play in the hyperosmolality of the medullary interstitium. Urea will come from the medullary collecting duct into the interstitium, increase the osmolality. And remember, urea transport is by facilitated diffusion. No energy is required for urea transport. Urea transport is from higher to lower concentration without using energy, but it requires transport proteins, which are called urea transporters. So all these segments of the nephron which are permeable to urea have got urea transporters. Tubular-glomerular feedback control is useful for which of the following? This is for the regulation of GFR. You could also say it is for regulation of plasma sodium, but better answer is going to be GFR. Impaired function of aquaporins results in which of the following? Impaired function of aquaporins, nephrogenic diabetes insipidus. Diabetes insipidus can be neurogenic or nephrogenic. Neurogenic, if there is decreased secretion of ADH from the posterior pituitary. Nephrogenic, that means there is a problem at the receptor level. Either there is a problem of the receptor or of the aquaporins. Just a brief reminder, which aquaporins are present on the collecting duct? Aquaporin